with us before. This is a reminder for those who are who are joining for the first time. These are some useful tips that you can use to make the most of the knowledge that we offer. First of all, let me tell you about our resources. If you type IFC IQ Healthcare in your web browser, there will be quite a few resources available to you that we prepared. First of all, it's a page that we are maintaining on the quality issues in healthcare. We've got a YouTube channel that has available the recordings of our previous webinars. So make sure that you visit it. And we also have some more resources. So this page summarizes what we have. So we have the page, we have the YouTube channel. What else? We do have a LinkedIn page that you're welcome to join. We have a Facebook community of practice. Now that is a closed group that you can apply and join. And this is for discussing issues about healthcare issues with fellow professionals from all over the world. We have webinars recorded, and actually there are already 36 and not 35. And last but not the least, we have free online safe-paced trainings. And those trainings are available in English, in French, in Arabic, and are also coming in Russian language for former CIS countries. We do have certificates available for each of those trainings. Those trainings cover international patient safety goals. Those trainings cover quality management, and there's a training on prevention and control of infection. Now, we will be sending you an email with links to those trainings, so make sure that you review and see if you can use them to refresh your knowledge or to acquire new knowledge. And for each of those trainings, again, you receive a certificate. Now, the most important part for many of you, please listen carefully. Upon the end of the survey, when you click on disconnect, you will be taken to a survey on exit. It's a very short survey, but it's a very important one. And why? Because also what you did before the webinar, you filled out information about yourselves for the certificates on this webinar. Now, if you made a mistake in registration, or if you want your name to appear differently, or if you have fellow colleagues joining together with you and they want to be included in the email list to receive their own invitations and their own connection links. Now, this is what you can indicate in the survey on exit. So this is the feedback that you want to give us. Please don't ignore, please respond, please let us know, and there is a reward. And the reward is the certificates for this training. Now, we did have some delays due to software issues in our previous webinar. We do apologize for that, and we hope that we will be able to send the certificates for this webinar within 14 days this time. So no more delays. We've sorted out the software issues. So the name and email were recorded, you have recorded, or you can indicate them in the survey of exit. You will receive your certificate within 14 days. Please don't start writing to us tomorrow, because tomorrow we only receive the lists of those who joined the webinar. We need to make sure that you stayed in the webinar for at least 30 minutes to receive the certificate. It's very important that you took something from this webinar for which you can receive a certificate. And in 14 days, that's probably January 1st, if you don't have your certificate, then please contact us, okay? Please be patient, because we cannot send you your certificate tomorrow, and we hope for your understanding of that. Now, while you're waiting, what you can do again are the training modules. And if you go to, if you receive an email, you will receive an email today or tomorrow thanking you for your participation. Those who registered but did not join today, you will also receive an email, and we know from some of your feedback that you use recordings and you watch our webinars. So we appreciate that. Now, in that email, there will be also links to our page with all the training modules, training courses. Now, those training courses are free. They are available to everyone. They are self-paced, meaning you can stop, you can go to your work or you can go to your family and join the next day from where you stopped, and you can complete. You can take as many attempts as you want, and those are and the courses are really useful. Now, this is a screenshot of our latest course, Prevention and Control of Infection. You may have taken our courses earlier, some of us. Now, this is the latest one. Also, we do have courses available in Arabic, in French now, in addition to English. Now, let's come back to today's webinar. There are two useful features. Now, there's an interpretation button on your screen. And when you press that interpretation button, you are given a choice of languages. Now, you can choose any language that you want to, and our interpreters will do a really great job to interpret simultaneously what speakers say so that you can understand better and make really good use of the webinar. Now, with this, I'm also asking our speakers to speak a bit slower than usual, keeping in mind that there's interpretation going on. And as I'm saying this, I'm starting to slow down as well. So we really need to keep in mind that there's interpretation going on. Our interpreters, they're fantastic. They're very experienced. But if we talk fast, then some things will be lost in translation. Another useful feature is chat. Now, this is where we can type as fast as we want. We can type about yourselves. We can type a welcome. We can type an introduction. We can type something that you want to share with other participants. What you don't type here are your questions, because questions are likely to be lost if you type them here. This is a chat, so this is just chatting, not getting your questions answered. Now, to get your questions answered, you use another button, that's Q&A. And when you press that button, there's a field, and the field opens, and you type your question, and that question stays there. And when we receive your question in that field, one of us will either respond it in writing in this field, or we'll bring it up during the questions and answers session at the end of the webinar. Well, that's about it. And I hope that this webinar is useful. I hope that you find the speakers interesting, and the slides that we will be showing today, we will be sending you those slides tomorrow with our follow-up email. So don't worry, if you missed a slide or two, you still will be able to see those slides in your email tomorrow or the day after tomorrow. Now, if you don't receive a follow-up email with the slides, not the certificates, just the slides and the resources, please write to us. Respond to the invite, and then we will send we'll send the email to you. And now we start the webinar. And once again, I'm happy to welcome everybody who is here with us. Julia, now the floor is yours.
Yes, hello, hello everyone. Thank you very much, Natasha, for this wonderful introduction. And welcome everyone to IFC series. Issue the question of quality dashboards. And before I introduce the first speaker, I actually wanted to ask you whether you can type yes and no to this question. I will post the question in the chat while you listen to our first speaker. And our first speaker, I'm happy to introduce, is Xavier Anton, emergency medicine expert and patient safety expert. Xavier
Yeah, hello and good morning, afternoon, or evening, whatever part of the world you are in. Thank you very much for joining. And I'm going to be sharing my screen and I'm going to be talking about healthcare quality dashboards. Okay, let me get my laser pointer. Thank you very much. So, a healthcare quality dashboard, the contents of this talk is the following. We're going to have a definition of healthcare quality dashboards. We're going to look a little bit at the types of dashboards that we can use. We're going to look at data, KPI, and how we get them into dashboards. We're going to examine some advanced types of dashboards like used in mature healthcare systems that have been using dashboards for a long time. We're going to be looking at live dashboards and how they help us in management. We're going to look at how AI can help us and improve processes by looking at dashboards. And then at the end, we're going to be looking at how can you get started. And we're going to discuss also a little bit the IFC benchmarks program and how can that be the first keystone for how you are building your KPIs for your dashboards. So, what is really a healthcare quality dashboard? It is a key tool to visualize data. Usually, what we visualize is key performance indicators, and that helps us to inform our decision making processes. We can use it also to monitor patient outcomes. We can use it to monitor operational efficiency, as we will see. We use it to monitor and increase patient satisfaction, and in some cases, to ensure regulatory compliance for some data that our Ministry of Health or other official organizations may be asking from us. What happens and what are the requirements from data that we have to have in a dashboard? We have to ensure the data quality. This is key. The data should be accurate and meaningful. How do we do that? We do it through validation. Validation is the process by which we check that our data is good. Typically, this is done by another person or another process collecting the data and seeing that we get the same results. Then the data that we have has to be secure. And also, we need to take measures to protect patient privacy so that our data is all anonymized. Then also, we should really customize the data because everybody in the different healthcare organizations looks at different things, and we have to tailor the dashboard to visualize what it is that we really need to see. How can we visualize this data? There are a number of types of healthcare dashboards. The most common one, perhaps, is the histograms, which we'll talk about later, and also the line charts and control charts. The difference between a control chart and a line chart is that the control chart has an upper and lower limit, while that the line chart is simply a line, as it says the name. Typically, this is used to track trends over time. In this case, what we are looking at here is total knee arthroplasties and length of stay in the hospital. So we see that over time we are pretty uniform in this case, and we are within the limits of what is expected, except for this 1 month. This enables us to go back and look what happened here, why our length of stay increased, and will give us key insights on maintaining our processes within the chosen limits. Bar charts is the simplest data display. If you use Excel, you know that Excel can automatically create many types of charts for you. Bar charts is very, very simple. Now, when we have different type charts, different bar charts for a same process, it enables us to look at different snapshots of a given problem. So in this case, we are comparing across different categories the response to a negative event in the hospital. So we're looking at how the healthcare provider responded. So we can see that the healthcare provider, doctor or whoever, did not deny responsibility, thought that the care was appropriate, there was no response, and so on. So then we have here that the patients, they had different outcomes from the same event, a negative healthcare event. So we look at the number of patients that had post-stress or an emotional disorder from the trauma. Some may have had financial loss, some may have had death, some may have had chronic pain, and so on. Obviously, negative outcomes influence the family as well. So we can see how the same event affects the families. The families can have emotional trauma, the stress of the caregiving, financial loss, and so on. So again, bar charts are very, very simple and enable us to look at very different aspects of a same event based on the number of responses or data points that we collect. Pie charts. Pie charts, I love them because they really allow us to look at, with one single shot, we can see a lot of data and how it compares to each other. Pie chart, as it says the word pie, it's like how we slice it, right? So we look at the proportions or the portions. That can be revenue breakdown by insurance, as we will see some examples. We can display key metrics at a glance, how it is bed occupancy and so on. In these cases, we are looking at here is the arrivals to a psychiatric unit, and we can see that depressive disorders were the most common that were being seen here in this crisis intervention unit. We're looking at anxiety disorders are being the number two, and so on. Gauges. Gauges also is a way very practical to look at key metrics at a glance. So, for instance, in this case, we look at customer satisfaction and how it is influenced by timeliness. So, in the emergency department, when the patients arrive, this gauge displays at 30 minutes as the time of arrival from the patient to the bed, 50 minutes for the patient to be seen by a nurse, 78 minutes for a patient to be seen by a physician. And this gauge, it shows us that this is in the red zone, and which is really obviously outside of the expected limits. And then from arrival to discharge being the total throughput, that is within the yellow range. Then based on these times, we see that the patient satisfaction is also broken down. And again, we have another pie chart showing us that the majority of the patients were very satisfied, thank goodness. So a map, everybody has seen a bunch of maps, especially related through the COVID. We were looking at the different countries and how every country had different rates of contagion and so forth. So we can look at maps. In this case, we'll look at healthcare expenditure as a share of the GDP, the gross national product from a country across the world. We can also, for instance, as we will see, look at how patients come from different points of our geographical service area to a given hospital. In broad categories, there are 5 types of dashboards. The first one will be looking at safety metrics. So in this case, we are looking at the number of incidents by incident type, and we can see how this is broken down in percentage, number of incidents. This could also be easily a histogram like we have here, and we see the number of related events to different things. So for instance, we have this one that was related to documentation, this one was related to behavior, this percentage, and we see that we can track also other key safety metrics, like it would be falls, medication errors, or infection rates at a glance. We'll see some examples of that towards the end. Clinical outcomes. In this case, we are looking at heart failure readmission. If we take good care of the patients, hopefully they will not be coming to us immediately. So in this case, this hospital has a 30-day readmission rate of 20%, and they are within their target, which is 30% out of 301 discharges. So this one looks at 90-day readmission. Also, we look at the utilization of the emergency department by this group of patients. And also, they look at if they needed an observation stay in the hospital. So that these readmissions, we can see them, how they get readmitted over time. These being our 30-day objective. And we see that this hospital, based on this pie chart, based on this histogram, is a little bit over for some months because this is the upper limit of their normality for their 90-day readmission. So this will enable us to also stratify the risk for these patients when we exceed the unexpected readmissions over a certain number. Patient satisfaction is one of the most common things that all hospitals follow. We can have different dashboards that look at the same indicator. So, for instance, here we look at patient satisfaction across different services: obstetrics, cardiology, family medicine, orthopedics, and we can see how every department compares. In this case, we can look at the patient satisfaction by referrals, and it seems to be that the patients that are least satisfied are the ones that come from these referrals, because this needle in this gauge dashboard falls in the red zone. We can look here at patient satisfaction across the years, and this would be our median expected patient satisfaction. Then here we look at the number of patients that rate us as a good hospital or superior to that. Another typical type of dashboard is when we look at operational efficiency. Here we have different dashboards that help us look at our operational efficiency. So we look at the average length of a stay in this area chart, and we see the length of a stay in days for a given month, for a year, and so on. We look at the 30-day readmission rate with the median expected, and for admissions and readmissions, we see how they compare. We look at the cost based on the different age groups. Logically, in this case, we see that older people would stay longer, length of a stay, and they will be more expensive to treat. So we look at length of stays by payer. So in this case, we look at this type of insurance, which is called Medicaid in the U.S., which is 31%, and these other patients, which are usually more elderly patients, they have a length of stay of 39%. Here, this is really not a dashboard, it's just a graphic representation of nurses to patient dashboard. And we see that in the emergency department or a trauma unit, the nurse to patient ratio is much higher. Finally, we can look at financial performance. This is a graphic display of a revenue cycle advisor. We look at the charge capture, and we see that this hospital is very efficient in capturing all the charges. These would be consumables, medications, procedures. So this hospital is really good capturing charges. Then we look at the claims management. Clean claim submission rate, clean claim, it is a claim that has no faults and that can go straight to the insurance. And the insurance, since it is the claim is clean, they will pay readily, which will really ensure that our revenue cycle is much shorter. This hospital is doing so in this gauge dashboard. So here we can look at our denial rate per reimbursement. So the denial rate is when we send a claim to an insurance and the insurance says, no, we deny you the care. And then in this case, the hospital is also doing very well in this dashboard. The bar, the histogram dashboard, it shows us the 12-month trend for the different areas that we look at, whether charge capture, revenue integrity, or reimbursements. So now we can look at advanced dashboards in a mature quality hospital system. Typically, a hospital that has been using dashboards for a long time, they will look at many things through a single shot. So In this case, we look at left without being seen. Left without being seen are the patients that leave an emergency department without being seen. Obviously, if we reduce the left without being seen, we'll have more collectible revenue for the hospital. So in this case, we see many different graphs that are all related at the same area of where the patients live without being seen, which is the emergency department. So these analytics with multiple dashboards, we can see is in this case, one map. We see where the patients are coming from. We look at the median length of stay by day of the week. We can look at the chief complaint in this dot graph, where the chief complaint, which in this case, it was chest pain. I know that the graphics are not so good here, and I apologize for that. Also, we can see at the patient volume by time of the day. So here would be midnight, and here would be midnight again. And we can see, as you can expect, that towards noontime, we see that the patients come here the most, and then in the afternoon, and then they start falling off towards late in the evening. We can see how the different age groups, what percentage we have. Obviously, younger people have less problems, and these are the least represented group. In this heat map here, we see at the length of a stay by time of the day. So again, midnight, midnight. And we see that this is more hot, more red. We see that in the afternoon, the patients that come tend to stay longer, and the patients that come early in the wee hours of the morning, they stay less time. So in this case, after looking at all this, the hospital looked at throughput and the staffing according to the volumes, and they achieved a reduction in their arrival in their left without being seen that increased the revenue by $567,000 per month by reducing the time to triage and the time to see a doctor, which is really one of the main indicators for the patients being satisfied. So the patients go to the hospital or to the emergency room to see a doctor. The longer we have them there waiting, the least satisfied we are. So in this case, they reduced that time from 33 to 16 minutes, resulting in a reduced length of stay of 65%. Artificial intelligence and dashboards. So in this case, the problem represented in this, what seemingly is a seemingly complicated dashboard, is the triage levels. So typically in the hospital, we have triage levels from 1 to 5, 1 being the sickest and 5 being the least sick. Here in this column, we have nurse A, B, C, D, E, F, and so on, different nurses. And every column here is a patient. So we see that the same patient was given a category 2, 2, 3, 4 by the different nurses. And here, for instance, in this case, we have much more coincidence. 4 nurses gave this patient a level 4, and other nurses gave a level 1, level 3, level 5. So we have other cases here where there is more coincidence, level 2, level 2, level 2, and so on. So the rater, the nurses are the ones that do the rating, variability in the literature is 0.41 to 0.91%. In this case, we are looking at an accuracy of 55%, which is really not so good. So there is just a moderate agreement on the triage level assigned. Why is it important at triage level? Because this gives us an idea of the risk. The sickest patients are more likely to be admitted, are more likely to deteriorate, are more likely to get an ICU bed. So what do? We take 150,000 visits, and we create an algorithm that will triage the patients based on risk. The risk is based on the patient's age, the gender, mode of arrival. That would be if the patient arrives with an ambulance, arrives walking, arrives by private vehicle, based also on the chief complaint, and past history. In that case, this will give us a risk, and the algorithm will assign a triage level based on the historical data that we give to the algorithm. So this will ensure consistency and will help us predict patient deterioration. So we see that for the algorithm in this histogram, the temperature, what is the risk value that it assigns. So when we look at heart rate, we see that is the one that has the highest significance in the prediction for deterioration. So we fit all this data into the machine learning, and they give us different levels of risk by the different categories. So the nurse can override the triage level 1, 2, 3, 4, or 5 if does not agree with the recommendation of the algorithm. So finally, we have 4 dashboards here. The first dashboard shows the level of discrepancy between what it is, this HOP score, which is the automatic score by the algorithm, and ESI, which is the most common used triage methodology of 5 levels. In the US, it's about 70% of the hospitals that use it. So for the major discrepancy is for level 3. So the algorithm was assigning different levels, as we can see here, for the different kind of presentations. So many more level 5s than the nurses. So then here we see that it's very good at predicting outcomes. So the patient deteriorating, very much predictability by the algorithm than the humans, especially for the sickest ones, which is the category 1 patients. And also the algorithm is pretty good at predicting admission from for the patients based on the risk assessment that it can do. So we have here representations in histograms, a heat map by the nurses, and also in this one, we look at resource utilization based on the severity level, the number of nurses that are utilized for each case. So managing with live dashboards. We see live boards in the US. Here, these hospitals advertise the waiting time to see a doctor. So that is immediate feedback. So they hope that the patients will go to their hospital when they have less time waiting there. So the hospitals use this by giving what is called surge management. So when they see that the length of the waiting time exceeds a certain level, then the hospital will assign more resources, more people to the triage, to the department that has a problem. So, for instance, hospitals use live management for bed cleaning and turnaround times, for laboratory turnaround times. In this case, we look at live data for metabolic panels, complete blood counts, electrolyte panels to see if there is a problem with the machinery. And in this case, they look at this dashboard represents the beds as they become available, and it will give us the turnaround time for each one of the beds as they become dirty. So how can we get started with dashboards? Well, the hospital usually collects data from patient registration. Obviously, the recommendation is that look at the data that you have. And then this data will come usually from patient registration. From there, what we can get? We can get patient volume, new patients and returning patients. We can look at the demographics, age, gender, insurance status, if they have had any surgeries. So we can also look at clinical data. So we can see number of surgical cases, the inpatient versus outpatient. We can look at C-section rates, or we can look also at patients' hemolysis rates or mortality for the different groups of patients that we have. We can look at our readmission rates. This data is usually available in all the hospitals. The recommendation clearly, it is to start small and do not complicate your life too much. So this way we'll, and also have really easy data, easy charts. So run charts, histograms are great. So in this example that we have as one of the hospitals that IFC work with, we started with this hospital a full assessment. We did a full assessment in October. We helped the hospital develop a quality program. We created a quality commitment with them, and we helped the hospital support in their KPI creation and development. So we see that after a few months, the hospital started collecting different types of data. We see that they looked at the mortality rates, patient identification. They looked also at the readmission rate. Also, they really looked at why they were being readmitted, and we see that they started having some success at preventing readmission rates because they had good information, which is something that they didn't do. This also shows the hand hygiene, which is a great tool to help prevent admissions in the hospitals. Then they also started embarking on something a bit more complex, and these are straight created from this Excel sheet where they started selecting the different indicators, complications, safe surgery, and so on, and it gives them immediately data because this is done in Excel. So the operations are clearly improved, and by the way, they review the data and then feedback through the different departments from which they are collecting data. A great way to start is the IFC benchmark program or service. You can participate, you can ask for information to IFC. IFC will provide a great data collection tool in form of an Excel sheet or Excel book. And we can look at operational metrics, like it would be bed capacity and utilization, intensive care, beds, number of ICU admissions, and so forth. All of these are very meaningful operational metrics. We can look at day case metrics in general surgery, in gynecology, urology, the number of surgeries performed for these ones, and for instance, pediatric tonsillectomies, and so on. We also can look at very meaningful quality indicators, mortality, infection rates, preventable harm, patient experience, and you can break this down. Great tool. It gives you a full set of indicators ready to go, and you can start slowly and collecting different sorts of data sets for the different types of indicators that the IFC benchmark program will help you collect. So thank you very much for your attention, and we'll be taking questions at the end.
Thanks. Thank you very much, Xavier. Yes, that's right. We will have our Q&A session later. So just to sum up, quality dashboard is a very important tool. Yes, it takes effort to get data, but still it's worth it. Why? Because it helps you improve, not only see what is happening in your facility, but also it's an important instrument to implement improvements because it helps you identify the areas that require improvements. So each dashboard important component is a graph, and Xavier described various types of graphs, and for certain indicators there will be specific graphs that are useful. Why graphs are important? Because they help you visualize and they help you do proper analysis, because analysis is another important point, another important part of quality improvement. Not only you get statistical data, you also need to analyze it properly. What does it tell you? Because here many facilities can potentially make mistakes, and then your statistics takes you to the wrong direction, and that might be very risky. So for proper analysis, please use graphs. And as Xavier already mentioned, start small. If you are just starting the measurements, do not try to be overwhelming and collect all data possible. Identify priority areas and start with them. As soon as you familiarize yourself with it, you can move on. Thank you very much for answering my question, whether you already use the dashboards or not. I could see that many facilities participating, joining today are already using dashboards, and that's great. So please prepare your specific how-to questions to our experts, and please type them in Q&A section so that we can address them and help you modify your dashboards and make them more useful. Another important point that I wanted to make, that you cannot adopt somebody else's dashboard. Dashboard is as unique as a fingerprint, and there are no similar dashboards for any facilities, because for each facility it serves a specific purpose, and each facility has specific patients, and all we can do is just learn from each other, learn in the knowledge sharing, and that's what we are going to do with our next speaker. So I'm happy to introduce our next speaker, that is Dr. Joan Osorombui, Chief Operating Officer from Mpisha Hospital, Kenya. Doctor, the floor is yours.
Thank you, Yulia. I hope I'm audible.
Yes, you sound great.
Okay, good. So I'll go right to it. Natasha, I'll request your assistance to project. So mine is to take you through an experience of running with quality dashboards in the Mpisha Hospital. And allow me to just begin with what drives us. Why are we Mpisha? What's the big deal behind us? So for us, based on the quote by our founder, Mr. Mpisha, who says, "I shall pass through this world but once. If therefore there be any kindness I can show, or any good thing I can do, let me do it now. Let me not defy it or neglect it, for I shall not pass this way again." And this is big for us as a guiding light. Next slide. Because it enables us, one, to remain inspired. And when we are concerned about what's going to happen, we remind our team members why we are here. Because for every patient, they are hoping that the person they will interact with will make a difference. But how do we make a difference if we don't know what has been going on? So I'll go straight to the next slide, definition. So for us, dashboards are a data management tool, as has been discussed. It gives us information to put necessary controls and to manage our units. But at the same time, it reflects the key performance indicators that are being looked at in the institution, right from the individual contributor all the way to the board, because we are answerable to our board members and to the community at large. Next slide. Therefore, then, for us, just as has been mentioned earlier, we want to ensure that we are measuring the right thing, what matters to the patient, what matters to the board, what matters to the person working beside me. We want to know what's going on around us so that we can be responsive. It helps us to reduce the time in data gathering. Once we are able to get data daily, we find it's not a struggle. What would have taken hours, days before becomes a 10-minute or 5-minute affair for the team on the ground. It reduces how much information we need to carry in our heads, because all we need to do is walk by a dashboard or open our computers and we can see what we need to do. It shows us the health of our departments. It reduces the time to task completion, and it improves compliance to guidelines. Next slide, please. So how do we decide which dashboards to look at? So we begin with place-based stakeholder mapping. And through the year, as we present our results to our board members, the areas of concern that they continuously raise become something that we trend to see. Are we making reasonable efforts to improve them or to resolve them? And the things that seem to remain pending by the time we are in the month of October, November, become the areas that we focus on. The second group of people that we look at is the patient. Without the patient, we are not a hospital. We don't exist. And so we trend the patient feedback that we get. We get it every day through a QR code system, which is linked to our health management information system. And therefore, every day, each manager is able to see written feedback from their patients. That is feedback that does not include the feedback we get when we walk on the ground with the patients. We trend it, we try and resolve issues. Once we have done that, we look at what has been the common trend through the year and then come up with strategies to deal with it for the coming year. The other stakeholder that we look at are our partners. And our key partners as a hospital, we have doctors who admit patients, whether they are employed doctors or licensed independent practitioners. We have suppliers who provide us with various consumables and equipments. We have corporates, because our hospital is a private hospital, and therefore about 70% of our patients have private insurance and the public health insurance. So we also look at feedback from these members, because if they are not happy with the services that we offer, they will not pay for the patients who need to see us. And therefore, we try and see how we can improve logistics in terms of patient care and authorization. Once we have evaluated what is key, the fourth stakeholder we look at is our staff. We say if you want to move from good to great, that have the right people. And we are very keen in terms of our recruitment process, that the people we bring on board, we believe in them and we know that they add value to the institution. So we are very keen to also know, what do they think about the services we are giving? What do they think about how we are interacting and working together? Therefore, they are also very key to be able to give us feedback. Once we have evaluated our stakeholders and we have mapped them, then we ask ourselves, what is the goal? And in order to meet this goal, what are the key questions that we need to answer? And what are the key metrics that we need to be able to measure to be able to meet these goals? Therefore, we come up with various dashboards, and just leveraging on the first presentation that we had, these dashboards can either be in terms of pie charts, line charts, bar graphs, and we have a bit of AI that we use as well. The key thing, in order to make them a push factor, we use different colors so that it's easy to be able to tell what's going on. Green, red, yellow is, we like to use the traffic light a lot so that people can easily tell what do they need to focus on. We also like to use different formats so that people can be able to tell, are the trends going up? Are they going down? Are they remaining at the same level? Is there anything we can do about it? Next slide, please. So there's some slides missing here. I think this is the old presentation, Natasha. So once we have done that, then we are able to tell, Natasha, I don't know whether I will be able to project, because I wanted to give examples of some tools that we have so that the members can be able to see. Allow me to share just this ones, then we will go back.
Sure.
So that
and let me get, I will connect with my colleagues and see what we can do real quickly, okay? Just perhaps you can show the part of the slides that are missing from my version.
No, you have a latest one, Natasha.
Using the GQM methodology, the goal, the questions, strategy, what matters at the end of the day. And therefore, as I wait for Natasha, let me just share something that will give us an idea. So for MP Shah Hospital, because our key purpose is to promote health and wellness to the people we serve, to try and give the premier patient-centered care, and we're a tertiary hospital. Both we get patients from East and Central Africa, and we are committed to excellence every day. So when we come up with the questions that we are asking, the key guiding factor is it patient-focused? Is it innovative? Is it trustworthy? Do I need some collaboration to achieve this? Is it compassionate? And therefore, then for us, once we have evaluated the goal, and this is our goal, we looked at our strategic pillars to come up with the questions that we will answer. And looking at our 5 strategic pillars, where it's sustainable growth, exceptional stakeholder experience and superior patient outcomes, operational excellence with international accreditation, highly engaged patient-centric teams, and financial sustainability. So based on this, we came up with our matrices that we measure. And how do we do this, and what dashboards are we using? So the first one that I'd like to talk about is MS Planner. And using the MS Planner, where we have our strategic goals, we have different plans. And for example, I am just showing us one that talks about our strategic initiatives. We are able to look at the grid to see, like we are on the grid page for this one. We are able to look at the board, which gives us different pie charts and different bar graphs that are able to tell us our performance of what's in progress, what has not been started, what has been completed. Again, the traffic board, the traffic light system, and it's able to schedule what we require. You can see the different charts are there, which depending on the user, you're able to choose what works for you, but the information is the same. The filters there enable us to, again, come up with different dashboards depending on what we want. We can look at the dashboards based on due date, based on priority, high, medium, low, based on progress, not started, work in progress, completed, based on labels. Like for this one, you will see the label is FSSG, that's financial sustainability and growth. We're able to look at based on buckets, and our buckets here are the 5 strategic pillars. And under the buckets, you can be able to even look at based on assignment. So I can go into the platform and be able to say, let me see what Dr. Juan's pending things are. And under that, what is pending for me, I can choose which strategic pillar to focus on or to look at everything to be able to deal. And when you open, you're also able to organize according to the dates that you want to look at them. Our scorecards then are presented in various ways. This is an example of a scorecard that looks at the number of incidents using a line graph. We have the median, where it's the target that we're looking at. We have the goal that we are looking at, and therefore we are able to see the performance of one of the matrices that we're looking at. We are able to use Pareto analysis, and in this case, when we analyze our incidents per year, we want to see where are 80% of the incidents happening, or rather 20% of the incidents that lead to 80% of the impact that we have. That helps us also know where to focus our resources in terms of time, in terms of people, in terms of budgets, so that we can be able to deal appropriately. So areas that have 0, then we do not focus a lot. But areas that are high, then we put all the effort that we have to try and reduce the number of incidents that we have. Over and above that, we then again have the different departments whereby we are able to look at their different performances of the different aspects. And I just gave us an example of a screenshot for us to be able to see. So depending on what level of operations you are at, these are online Excels that are filled in daily for us to be monthly for us to be able to see the performance of the different teams. You're able to see what's the performance of a different divisions and how can we support them. And this now then cascades down to the departmental level. Once we have seen what is required at a strategic level, which is our goal, then looked at the key areas that we need to focus on, we bring it down to what is to be monitored at the departmental level. And we have what we call our daily Kaizen boards, because as an institution, we have adopted the Kaizen methodology of improvement so that we can be able to have 10-minute daily Kaizen meetings in the department for people to know what's going on, where are we at, what do we need to focus on today, who do we need to collaborate with to achieve. And they have 3 main areas we look at. It looks at the people, the performance, and Gemba. Gemba means the actual workplace. So each department, and I'll show you an example of one, has this. Under people, we have a photo of the team members so that it's easy for us to know who we are working with. We look at the daily attendance, who's present, who's absent, who's on leave. We look at the skills matrix because there's what is required for different people so that we are able to tell whether people are growing, whether people are developing and improving themselves in the workplace. And then we have a staff development plan that is based on the skill matrix. And the staff development plan shows us the focus areas for either the different months or the different weeks, the learning that needs to be done. And we have a methodology of even how the learning is done. 70% is done in-house, 20% is outsourced, 10% we send people out of the institution completely to go and learn. Then under performance, we're able to look at our process KPIs and our result KPIs. So the process KPIs, as had been presented, mainly look at things like the turnaround times of various service areas to be able to deal with them. And the result KPIs will be able to look at the various outcomes that are required in a department. Then we go to Gemba, the workplace, where we look at the leader standard work. What is standard work that's required in this department and who is it assigned to today? We look at daily equipment checks. We have critical equipment in the different departments so that we ensure there's 100% uptime. We have a safety chart, and this safety chart is important because if an incident happens, we have to put it up and be able to use it to train the rest of the team on what to look out for. We include the OSH committee, the Occupational Safety and Health Committee, to be able to come and guide us and support us to come up with the right ways to deal with safety issues that come up. And then finally, we have a communication plan. And the communication plan enables us to be able to communicate key things that people need to know that have been communicated from management or that have come up due to reviewing processes or doing root cause analysis as part of closing out incidents. The bottom bit, which is called a 3C chart, looks at any issues that are happening in the department. And basically, anyone is during the 10-minute stand-up meeting, brings up any concern they have. The team quickly discusses the cause, and then they discuss the countermeasure. And the 3 Ws, which I will refer to as WOW, we talk about what is the countermeasure, who will be responsible to execute the countermeasure, by when will they execute it. And then we have a status. N means it's not been started, C means it has been completed. And then we have to do a root cause after that, where required. Again, when we are doing the root cause, we need to say what the root cause was, who is responsible, and by when will it be closed. And we monitor this so that whenever we walk into a department and we want to know what's going on into the department, this is what you will see. So this is a radiology department departmental scorecard. You can see right there, they have their meetings every morning between 8:15 and 8:30 a.m. And you can see the 3 areas. On the extreme left, we have people. In the middle, we have performance. At the end, we have Gemba with the safety charts, the leader standard work and all. And you can see the picture there enables you to be able to recognize who are the people in the department. We have team attendance. You can see it's in green, yellow, and red. As I told you, we like to use the traffic light sign so that we know what's going on. And then below there, you can see the team skill matrix. There are people who are fully trained, others have 75% training, others 25%. And this is what advises the training schedule or the people development plan. In terms of performance, depending on what it is, you are able to appreciate the various bar charts that are represented on the board so that people can be able to see their performance. And this is per month. And this monthly performance, usually the managers are able to have it on their computers and represented per month. So that you can see the whole year in detail. But for the people on the ground, we want them to be able to see what's going on per day and to make the necessary changes per day. This is the bottom of that DK board that you can see. And you can see it even has departmental customer service scores that are there so that people can be able to appreciate. And at the bottom, you have the 3C chart where we bring up any concerns, find out what are the causes, and then we work on the countermeasures. And it has who is to do it, by when, and what is to be done. What are some of the challenges that we have had to deal with in regards to this? So first and foremost, we had to come up with local terminology to be able to appreciate the work that we are doing. And so therefore in 2022, we held a competition in the hospital because we realized quality dashboards had different approaches depending on what methodology we had picked. We have ISO, we have JCI, we have Kaizen, and we asked ourselves, can we have one name for this project so that when we say this name, then people are able to know that we are talking about quality in the hospital, because quality is not just clinical. Quality is customer care. Quality is financial. Quality is how we engage our staff. And so then the team came up with an acronym called AMWA. AMWA stands for Decide in Kiswahili, and it stands for Always Maintaining Uniformity of Awesome Care. And that is the terminology now we use for our quality improvement. So if you hear Project Amua, Je umeamua, then you know someone is talking about quality. And it's an active word that says decide to do right. So that's the first thing we needed to come up with so that we are not fighting between Japanese terminology, English terminology, and different terminology. The next thing that we needed to do in terms of ensuring that the process works well was to get buy-in from the senior managers. It's interesting that it's not buy-in from the front line, because we appreciated, and in Africa we say that the fish rots from the head, that if our senior managers do not have buy-in into what the quality dashboards need to be, if they are not the ones following, if they are not coming on the ground to be with the teams and monitor progress, that it doesn't matter how much we sing, but we will not get there. So that was a big thing we needed to do. Why aren't I talking about our board? Our board had already given sponsorship through having allocated budgets to support quality in the hospital, and now it was the senior management to drive the process and make sure that it picks up. And then finally, in terms of outcome, a big thing that we found as a challenge was ownership of results. And so what really worked for us, and that's why I focused a lot on the 3C chart, was ownership. So when we came up with the WOW methodology, where we say, what is the problem? Who is going to deal, who's best placed to deal with the problem, by when will they deal with the problem, we began to see a change in behavior. We began to see quicker improvements coming up in the hospital. What are some of the bouquets? We've enjoyed the spirit of adventure through the competitions to find out what to call our quality journey. And twice a year, in March and in September, we have a whole week of just celebrating quality based on the various focus areas that WHO comes up with. And so we've made it a fun thing. We have competitions, we have plays, we have art competitions, we have music competitions where different people do different things, and we are able to get everyone rallying around it in a fun way. Visionary leadership, and I must appreciate our board. Because when people were overwhelmed and were not moving on, it's the board that kept pushing and asking, what are you doing about the Kaizen journey? What are you doing about quality? We are not seeing it being replayed or being displayed, and the results are not coming out. And so just their push and that accountability that we have to give reports every month on our DK boards, on our customer experience, on the outcomes that we have, means that we remain accountable all the way to the frontline individual. The wow factor I've talked about, and we've used various platforms to be able to bring out this wow factor of what, who, and when. So all staff, for example, have access to our HR dashboard where they're able to look at their own individual balance scorecard. And this is a live document that they're able to review together with their managers. We have the manual DK boards that I have shown you that every 10 minutes per day, the teams are able to rally around and see how do we improve. We have online Excel boards where people are able to see different performances that or different levels of performance of the different members that I have shared. But we also have Microsoft Planner that when work has been done and the planner keeps updating and alerting you, this is pending, it's due by this date, so that people are able to do their work and the different dashboards are updated. Then finally, a thing that we have learned is if you truly look at what you have, you'll realize that you have what you need for the next level. Whether it's your health management information system that has a report dashboard, or you can have a report builder when you coordinate with your consultant or your provider, or whether it's your Outlook or Microsoft 365 that can be able to give you different options for you to utilize. And why do I say that? For MPSHA, we've decided to utilize and optimize all the platforms that we have without having to buy extra. So, for example, from Microsoft 365, we're able to use our Outlook for emails, reminders, calendars, OneDrive for online documents and shared documents. We all know Word and Excel and PowerPoint, but a key thing is SharePoint, especially for shared projects that are working in the institution, so that uploads are done immediately and we can get reports, Teams for meetings, Power BI, which is doing a lot of analytics for us, especially in terms of TATs, in terms of our financial matrices that we have. We have Planner that enables us to bring together, or rather make our strategy become easy to implement because we can follow the various actions. We have used different power apps, especially for our employee programs, so that from power apps we have our mentorship programs which build into our skill development in the hospital, and we're able to tell if people have mentors who are supporting them, whether it's at a peer level, whether it's reverse mentorship. We have Viva, which we use to celebrate different staff members who've done something commendable. And at the end of the year, we are using it to be able to come up with Employee of the Year recognition. So whatever you have, we'd like to encourage that optimize the resources you have. And you note I've not talked about ERPs and HMISs, which we also have on the ground. So what are the key takeaways for us? Dashboards should have data that is relevant to the next person. If the data is not relevant, there is no motivation to measure it. Use the push methodology where you have different colors that enable you to quickly see what is the level of engagement, the level of completion, the level of attention that is required, so that it's not something that someone has to take a lot of time to see, but they can quickly look and say, we are in the red, or you're doing a good job, please keep it up. It's a continuous process. It's not an event, but a journey. And even as I share this, I must tell you that we have tried different platforms as an institution to be able to find what works for us. And as we continue, we keep improving and optimizing the tools that we have as an institution. But the other thing we've also learned is not to have too many platforms, because it can also lead to AI fatigue for your members. And then use visualization that people are able to accept. The wow factor, what needs to be done, by who, and when, so that you have ownership and you are able to keep people accountable. And finally, employ technology as much as possible. So allow me to finish with a quote. If you want to go fast, go alone. If you want to go far, go together. And I hope the imagery there is able to demonstrate that nothing is impossible, and what you have is actually enough to take you to the next level. Thank you very much.
Thank you so much, Joan. Thanks a lot for sharing your journey and the journey of your facility and your experience. We believe it's very important and very inspiring. I think it was for all our participants. And I just wanted to, before I introduce the third speaker, I just wanted to conclude a little bit, just to say that, yes, John made a very important point that all measurement and all creation of the charts and the dashboards is a team effort. Unfortunately, you cannot outsource it. You cannot outsource it to the quality department. You cannot outsource it to some external vendor or some external agency that will be doing it for you, because there is a role in it for every staff member, for every department. And that's why it's very important to motivate them. And thanks a lot, Joan, once again for sharing tips and tricks and key takeaways. And Xavier did that as well. So hope you will be, again, as I said, inspired by all this sharing, and you will be able to modify your system so that they become very effective and help you a lot. It is noticeable, and many facilities say that gathering data may become tiring because it takes effort, because they say, oh, there's a lot of red tape in it. But if you really treat it as a team effort, do not take too many KPIs to measure, but go gradually, stage by stage. If you motivate staff and pay attention to your staff role in it, then you will see that it's actually a very helpful tool, but not additional burden for you. So just once again, I saw some comments that said that some information on the slide was not visible. This is the specifics because some graphs have very small font, that's true. But please do not worry, we will share all the slides with all the participants after the event, and you will be able to see everything that you didn't see well once again. And if you need, you can even print it out and use it in your daily activities, because as you could see some graphs, it's very useful to print them out, and please use this methodology in your daily life as well. Now I'm happy to introduce the third speaker, and that's Dr. Abdul Hassan, Corporate Director Projects from Shifa International Hospital, Pakistan. Dr. Hassan, you're welcome.
Thank you, Yulia. Thank you so much. I have started screen sharing. I believe it is visible.
Yes,
it is visible, yes.
Thank you. So just a brief introduction about the organization that I work with. I work at Shifa International Hospitals Limited, which is basically a joint commission accredited organization in Islamabad, the capital city of Pakistan. And we have about 52 clinical specialties, 4 active transplant programs, including the liver, kidney, bone marrow, and the cornea. We also happen to be one of the largest intensive care provider of the country. So we have like 35 postgraduate training programs, and the list goes on. If we look at our journey so far, we have been successful with the Joint Commission International first time in 2017, and then we have had our first reaccreditation in 2020, and then lastly in 2023-24, we are accredited for by the AHA, ASHP, and ISO 901 for quality management systems, food safety, and environment safety, etc. So if you look at the environment that we are operating in, we have, this is one of the 5 hospitals that are Joint Commission accredited in the country right now. And this is one of the largest or most populous country of the world. It's I think at number 5 or 6 currently in terms of number of people. And if we look at the number of healthcare staff that are available to provide care to different segments of the community, then we are not very well equipped in number of in those numbers. So for example, when we are talking about number of doctors per 1,000, so it's only 1. And if we look at the number of inpatient beds to facilitate 1,000 per 10,000 population, it's only 5.1 compared to any developed nation where we have numbers like 50 and 60 and up to 100. So now, how do we address such challenges? There's a significant gap that exists right now, and the country is economically challenged in different ways, and healthcare is designed in a way where we have almost 70% of the healthcare being taken care of by the private sector, whereas only 30% by the public sector. So one way was that we need to maximize the utilization of our existing staff. And during COVID, what we learned that if you go outside your boundaries, not only you help your your patients at their home, but also it opens new ways and it gives you new grounds or arenas to provide care to the masses. So basically, we're talking about eShifa, which is an outreach partner of Shifa Healthcare, and it's like Uber of healthcare. And the best thing about it was that we basically got accredited by the Joint Commission, becoming the first South Asian organization to offer home care services within 6 months of its inception. And the services that we started were a wide range of services, including home nursing, home pharmacy, physician care, physio, and a lot of services that the patient needed at home. And this all under the Joint Commission accreditation umbrella. Now, this is definitely a different model compared to traditional healthcare. And when we are talking about traditional healthcare, we have our fixed structures, and then we have our own organizational plans that we are dealing with. But even if we look at the non-traditional healthcare models like eShifa, the process remains pretty much the same. And how we identified our data needs, we looked at what the mission of this organization or the vision would be, and from there, what would be the organizational objectives, what are going to be the regulatory requirements for us, that or the environment in which we would be operating all these services. We were definitely looking forward from day one to get Joint Commission accreditation. So definitely those things would be coming in. Then we had our own strategic plan, which we need to take care of in terms of what services would be started initially, and then as time progresses, what areas or services can be added and expanded. And that again is linked with our operational plan and operational reports, financial data. So all these things, they help us identify what kind of data we would be looking up to, and then definitely that data would be collected and utilized for further reporting and utilization. So if we compile all those things, then we basically had a map. We could identify based on all those requirements what exactly is it that we, in different segments, if we club them together, and then we can put them all on a couple of sheets where we identified what kind of indicators we would be, requiring to assess the kind of services that we're trying to provide to our patients, and also how these patients are getting our, the quality of services provided by the staff. So on my left, if you see on the left of your screen, you see patient-specific themes, and on the right you have people-specific theme, where we, on the rightmost, you also have financial sustainability, and IFC benchmarking was discussed earlier. So we have, IFC benchmarking as one of our key themes that we are looking at when we are, measuring data. So this is how we are starting the strategic data planning. And once we have started that, then the next most important thing is that, as it was mentioned quite a few times today, that you have to know, you have to engage your team that is on the ground to make sure that they can utilize the data, because it's for them. Once they start utilizing the data, that is exactly what you want, to own the data, to give you the best results. Because once they start doing that, it becomes pretty easy to do anything, to bring a change. You know what exactly is happening on the ground. So you need to know your audience, and that's specific for each kind of KPI or any measure that you want to select. You need to be very specific that what is your target audience. Then you basically get engaged with the data team, the end user, the leadership. They have to come together and then identify. There are various tools that we have discussed today. We right now are using Google Forms for collection of data. It's a pretty easy, simple tool, and then definitely it gives somewhat control over what can be added or not edited. So that's the basic data collection tool. Over it, then you can have some major data collections, or some data sources that can be downloaded directly in the form of Google Sheets or Excel from your existing databases. And then on top of that, you can have analytical tools like Nime or Python or R, whatever your organization is comfortable with. You have to identify something that works with everybody. And on top, the place where you actually start, putting all things together and start bringing out in the form of dashboards. That's the power of BI for us. Different organizations again are using different tools. Some are using Tableau. So it's again your call. We find Power BI one of the most compatible ones with our systems. So it's pretty easy for us. And again, it gives you, compatibility with AI tools as well. We have been saying that we are going to deal with a lot of numbers and a lot of data, and keeping everyone engaged and trying to maintain focus of everybody in the same direction. It's the key. So there was at one point in time in our organization that we wanted to, transition from first edition of the Joint Commission standards for home care to the second edition, and we started, working on different areas that included the policy development and the selection of KPIs as required by the second edition. Then there are specific clinical documentations that are required. There are changes in the practice that needs to be made. So all these things, when they're going in parallel, so how do you know that where the organization has reached? So only one speedometer on the top is exactly telling you where the whole organization is, and everybody is working, hand in hand and trying to reach a common goal of making sure that we cross the we increase and go to the 100 mark on this speedometer on overall compliance, and that is only possible if we drill down and we see on the subsequent sections that how different people came together and put all those effort to reach there. And sometimes it's just simple numbers in context of volumes. That's where we started. When we started eShifa, just simple plain numbers. That's all what we were starting with, and then gradually, as we transitioned, we had to select one tool. Our first tool, definitely across the organization, was Run Chart. That over time, as we have learned earlier, that it gives you information over time, and it compares your information over time, and it's one of the simplest one. For other things, then we started making it more detailed, like in terms of incident data that can be seen across the organizations in different departments, what's going on at different levels, and then which areas of the hospital are showing any specific trends or seriousness of incidents or nature of incidents, like medication error, God forbid, is happening somewhere, or it is a delay in medicine or anything like that. So you can look at your data, and then by area, by slicing down or drilling down the information, you can definitely go into the information, and you can take specific actions that are as required by the data. With respect to the change management, this is one example that, as I was mentioning earlier, we had like 192 standards, and for each standard there are about 4 to 5 measurable elements, and for each measurable element we had identified who is responsible and accountable. Basically, Raki metrics was applied to each standard, and then again against each we had identified if there was any policy requiring measurable element, and then if there was any KPI that was required, or anything that was specific to that measurable element. If you look at this specific data right now, or on the table, this is for the end user, and it identifies exactly what needs to be done and who will do it. But if you go to the next one, now this is at the director level, where people who are directing their specific departments, they can see exactly, or those who are responsible for specific chapters of a specific of this Joint Commission journey, they would be looking at as a whole where exactly the problem is, or what exactly is missing somewhere. But if you need to drill in terms of outcomes, then you have a specific indicator like patient identification, if it's throughout compliant or not. So if we see here, for example, so we see patient identification compliance overall is 100%, and then there are two subcomponents of it, which both are again availability of complete information and legibility of ID band. They're again both 100%. So it depends again who is the audience and what you need to show to that person. Then in terms of volumes, what we did, we basically again connected the different services, revenue mapping with the geographic mapping, and then type of services. So this helped us in deciding what sites or what areas and what kind of services that we need to design in different parts of the country. At the end, then we have a organization scorecard where we basically bring all those indicators that belong to different categories, and then they culminate into this, and then we exactly know that what the organization stands at. Since, as I mentioned earlier, eShifa is one of the sister organizations, what we have done is at enterprise level, we are collecting data at multiple forums. So what we do is at level 1, we are collecting data at each organization and their own department. But and this takes usually 1 week. It's a monthly cycle. So usually what happens is that in the first week of the each month, the data is collected, and that data again is presented in the level 2 meeting, where the departments, they have their own data meetings, and they present their own data that are collected and validated by that time. And at the third level, which is at the organizational leadership, this data is presented to the leadership of that specific organization, and any things that is identified or to do is identified, that is taken care of. And finally, at the enterprise level, where all the different segments, they come together and present their own data. So takeaway from my side, basically, plan data needs, as it has been mentioned earlier, according to your resources that you have. And secondly, the dashboard should be flexible enough that you can have the same dashboard used by a novice and the same dashboard used by an expert. So it has to be designed keeping in mind that people in the organization are going to have extremely variable understanding when it comes to technology. So you have to make sure that you cater to needs of everyone. So thank you from my side. Any questions? I'll be welcome.
Thank you. Thank you very much, Dr. Hassan. And I just wanted, before we move to the Q&A session, I wanted to conclude a little bit, so that dashboards are used by facilities of all levels. Those who are very mature and those who are not yet mature, it's useful for all of them to use dashboards. The difference will be that the dashboards will have, for those who are yet starting the journey, will have simpler graphs and most likely will have less KPIs measured. For those who are already advanced, the graphs will be more complicated, and there will be more KPIs measured, of course. Sometimes you can drop certain KPIs as soon as you reach a specific target, you implement certain process compliance with which you are measuring, you can drop the KPI and start using another one. So there is no point measuring for the sake of measuring. You need to measure what you are trying to improve. Or where you need to identify areas for improvement. In this case, this exercise really becomes an effective tool, because this exercise really takes effort. And also, it's important to use good your staff help. And we received lots of questions on staff motivation, how to motivate staff, how to make sure they participate in it, considering their workload. And that's what we are going to discuss now. So now we are moving to your questions. And the first question, we received actually multiple questions on this topic. So we discussed today multiple platforms. Some hospitals mentioned that they use Excel for this. So just some advice, some more advice from our experts, how to choose a good, reliable platform for building good quality dashboards, and some specific advice for beginners. Is Excel a recommended good start for those who are just beginning, or maybe some other platform can be recommended? That's the first question. Who wants to be the first to answer? Xavier, I see. Maybe you want to be the first.
Yeah, thank you. It's a very good question, actually, because you really always wonder. Cheap one, Google. It's free. So you have a Google spreadsheet, Google Sheets that is compatible with Excel. It's free, it's online, and you can work from it at the cloud. It has good examples. It's driven, it will just select the data that you need to display. And the same way in Excel, it will just give you several chart examples from which you can pick from. The other advantage is that by being used, by being based in the cloud, if you want, it's really a great platform for multiple users to share. So cheap and simple. What else can you ask for?
Thanks a lot, Xavier. Dr. John had a hand. Dr. John, what platform do you think is the best?
I agree with Dr. Xavier. The only thing I can say you need to watch out for, which we learned, was because we initially started with Excel, is be careful who you give access rights to. Because there was a time we realized someone had closed all our tasks. He was just ticking done, done, done. And when we reviewed, those tasks hadn't been done. But he thought that by ticking done, it is done. And yet it needs to be accurate, a presentation of what's on the ground. So those with access in terms of editing need to also be responsible, not just anyone. That's the thing.
Thanks. Thanks a lot, Dr. John. Very useful piece of advice, I must say. And also, I wanted to stress once again that dashboards become very useful for networks, because sometimes, especially if there is a corporate level, to get transparency about what's going on the ground, what's going on in different facilities, and benchmark, compare the results of the facilities. Dashboards become a very, very useful tool. So next question is actually somehow connected with the first question about the platform. That's the use of artificial intelligence. It's becoming not some kind of rocket science, but now a normal part of our life more and more. So how to use it effectively? Should we use it effectively? At what level should we start using it? Can we start it from the very beginning, or better first use our own brain for analysis? So let's discuss this topic, because it's very timely, I think, for many.
Yeah, do you want me to take this one?
Yes, please, let's start.
Yeah, from the hospital standpoint, what you need is good predictive data. Usually the things where you have the biggest expenses is your fixed volume expenses, like personnel, and then also your supply chain. Your supply chain is really where you can make huge savings by integrating. Now, you need to have enough data, because you need to train your AI model to give you predictive data. But let me give you a typical example for a large organization. Hospital formulary. You may end up having, let's say, for a hospital of 2,000 beds, you may have approximately 3,000 different molecules. And each molecule has different brands, you know. You obviously have different insurers that will help you, that they will reimburse you differently for each one of the molecules. So AI, well, it's not even AI, it's really more heuristics that will help you choose which molecules you use the most, and in what areas of the hospital, or if you are a hospital chain, even better, and it will create big savings. Also, if you have different hospitals, it will help you identify which ones are your fast moving items and your slow moving items, so that you reduce your expense in expired medications that are unused. So the AI will predict what is going to happen for the next 6 months, for the next 1 year. So it's really a great revenue enhancer, and also it helps you decrease waste. When we talk about medication, we can talk about other things in the supply chain, consumables, and so on. But if I had to use AI, that would be the first one. The second one would be, which is already available, is imaging, of course. AI is very good at imaging. So, you know, we have seen examples in places where they have high volume of immigrants. For instance, you can say any of the Gulf countries, Qatar, UAE, and so on. They may have 5,000 chest X-rays in a day. So the AI will help you weed out those immediately. For more accurate things, like it may be prostate cancer, breast cancer, also in areas where you do not have good people reading breast cancer, mammograms or ultrasounds, AI is a fantastic tool to really help you diagnose. Sergey Brin from Google used to say that AI will never replace the radiologist, but the radiologists that use AI will replace the ones that don't. So.
Thank you very much, Xavier. Dr. Hassan, and what's your opinion on the use of AI, specifically in measurement analysis, and would you recommend using it or not? Dr. Hassan, yes, please.
Sorry, Yulia, I just had a bad internet connection and I think I could not hear you properly. Can you please repeat that?
I see. Yeah, it's okay. So what's your opinion on the use of artificial intelligence, and would you recommend using it or not?
Definitely, it's
measurement. Yes.
Yeah, definitely it helps in predicting the data that what can happen or what can go right or wrong in the coming times. It can guide you through that. It can pick up those fine details that usually we might be missing out on. It can definitely add value to your analysis. But end of the day, what matters most is that at times, data is one thing, and then the social implications and the other aspects of the decision that will come into play once you make such decisions, they also, I think, needs to be taken care of while making such decisions based entirely on AI. So AI can tell you based on the existing data, for example, that your organization will do XYZ financially, but it cannot predict the political environment or the other environment that you're operating in, at a specific time, how it can change, the global changes that are taking place, it cannot predict that. So it's only as good as the person who is basically, at the end of the day, going to use that information. He has how good he has an understanding of the entire thing.
Thanks a lot, Dr. Hassan. Very valuable observation. Yeah, I would say it's good to have, but it's definitely not an obligatory component not to start measuring and not to start analyzing. Oh, we don't have artificial intelligence yet, so that's why we wouldn't measure. Xavier, you have a hand.
I would just add a comment. Let me give you an example of a very good quality improvement project and service improvement achieved through AI. A stroke unit with a very high volume of patients in the emergency department implements AI in their CT scan. So the CT scan within 8 seconds of having the test done will read if there is any bleeding, any stroke, any abnormality. It's really great detecting bleeding and strokes. So in the long list of X-rays to be read, the AI tool will automatically bring up to the top of the list the study that has the abnormality. So in this case, you improve your service, you improve absolutely patient outcomes, because in places where they have thrombolysis or interventional neurology, you really get to these patients on the average 40% faster than that. And then what I was mentioning before about the mammography. Kazakhstan instituted a very good project with remote mammography in remote areas. It's a huge country, right? With very few people. So the AI also helped in the biggest killer of women, which is breast cancer.
Thanks a lot, Xavier. Just a small remark. We are already exceeding our scheduled time a little bit. We will stay for another around 5 minutes, just because we received so many questions, and I think it's important that our experts address them. So thanks a lot for staying a little bit longer with us. And the next question is actually partially already answered by Xavier, because the question is, how can quality dashboard improve patient outcomes? Because it's basically about patient improvement of everything in the hospital and the medical facility is about improving patient outcomes. That's the most important thing. So we received multiple questions on the examples how dashboards can improve patient outcomes, and can they? And also, how can they prevent errors, specifically medical errors? And do they prevent medical errors? So let's discuss this very important aspect, please. Dr. John, do you want to start this discussion, please?
Yes, I can. Quality dashboards don't prevent errors. It's how you interpret them that prevents errors. So that's why it's a big thing and both Dr. Savia and Dr. Hassan have said it, and I think I showed it, having dashboards that are easy to understand, using colors that are easy for people to tell, whether it's red, yellow, green, whether you use a gauge like a speedometer like Hassan showed, or whether we use line graphs to show that things are running well or they're going down. So it's how we interpret that dashboard and whether the team is able to appreciate the impact of the dashboard. And it's important for me to also add, we've had also, as a leader, you need to be clear, because sometimes we have some dashboards that are bar graphs, whereby performance is better when it is lower. And therefore, the lower it gets is when it gets green. For example, average length of stay, you don't want to see your graph going up. You want to see your graph going down, because the shorter the patient's stay, we assume the better the clinical care that you're giving. So no, the dashboards do not prevent errors. It is we and how we understand them that enables us to prevent errors. So make it as user-friendly as possible and as simple as possible.
Excellent, Dr. John, thanks a lot. So anything from Dr. Hassan or Xavier to add?
Yeah, I think I totally agree with Dr. John. She just nailed it. I believe, the only way that they can act as something to motivate. So, for example, if you have displayed, 0 falls since 365 days, or something like that. So everybody is trying to stick to it, that will not let this happen. So it's one way of encouraging staff that, see, this is an achievement that you have made. So, it all depends that what you're trying to project to staff. If you're trying to show them that this is their achievement, definitely it would motivate them, and it would, at the end of the day, reduce errors. So this can, indirectly, we can say that it might help, but not directly. Definitely, this is data at the end of the day that is telling us on a presentation. Yeah.
So true, Dr. Hassan. Sorry, and I actually thought, sorry, Xavier, just one little comment. I thought your speedometer diagram was very motivating. I think that's just an example how the form of the graph impacts and solves actually multiple purposes. Yeah, even motivates staff, because you really feel like you want to achieve 100%. Sorry, Xavier.
No, it's no problem at all. Totally agree with my colleagues. Just want to add some coattails to the commentary. Look, if you are measuring things and you are achieving 95, 100%, for God's sake, stop measuring and or stop the frequency of measurements. Just measure something else. Use your energy into, you know that you got it, just every 6 months or so, but then start measuring something else because otherwise, yeah, it looks great to see 100%, 100%, 100%. Also, sometimes I doubt of the 100%, 100% all the time. So Yeah, just that comment. Thank you.
Thanks a lot, Xavier. Actually, I now have the last question, and this is a great connection. Your last point is a great connection to our last question for today, the accuracy of data. How to make sure that the data collected is accurate? Any tips, any advice on that? And how to train staff, or how to designate staff to make sure that they collect the right data, because wrong data becomes risky and dangerous, and we all know that. So let's take this last question.
Yeah, well, in slide number 3, I was point number 1 was data validation, correct? And I think that my colleagues they can wholeheartedly agree with this one. And everybody then, oh, how do I validate data? Actually, I saw some questions in the chat, and what I said it holds true. The easiest way to validate is to have somebody else measuring the same data set, the same objective, the same process, and see if you get the same results. Once you validate that this is a good methodology, continue running with it. That's the easiest way, I would say, data validation.
Thanks. Excellent point, Xavier. Thanks a lot. So, John, how do you validate data?
The easiest way is what Dr. Xavier has said. The other thing is to look at it in a different way. Sometimes you can expose the data to different methodology to see if the results come close, what the standard deviation is. Maybe that's a bit advanced, but that's the second way, especially where you have analytics, so that you ensure that there is accuracy. Yeah.
Dr. Hassan, how do you validate? Just the last point.
So basically, we have identified something along 7 or 8 scenarios where whenever we are selecting a new KPI, for example, so we need to make sure that the new KPI is validated. The data for collection methodology is new, or anybody who is new to the process. There's a change in process. Then again, we are measuring the performing the validation process. There can be a reason for validation, like we are going to make some data public that needs validation, data being submitted to any third party or website, or even the population of data that we are working with. Is that changing, or going from soft paper-based data collection to the digital formats? So these are the reasons usually when we are collecting validating it, or one reason could be there's a significant change. You see something happening differently entirely. You again go back and validate your data. But now the question is, how do you do, as Xavier was mentioning, we actually take the same data source that initially collected the initial data and gave that specific result, and gave it to somebody who understands equally and is well trained equally, and then performs analysis on the same data and then comes up with results. And if these two values are not matching, significant gap or variation exists between them. So for us, for example, in certain cases, we are accepting up to 5%, in other cases like 7%. So if there's significant variation, then definitely something needs to be done.
Yes, thanks a lot. Yeah, very valuable, Dr. Hassan. Just also to name cases specifically when validation becomes critical. We are running out of time, but we have our IFC expert in patient safety, Manuel Giraldo, with us. So Manuel, you have a hand. Maybe you wanted to make some important remark. This is your last chance.
Just quickly.
Yes,
just quickly, Julia, thank you. Just about the validation of data, I use process mapping and flow charting. So basically, I process the entire issue or whatever I'm trying to achieve, and then I measure times of data just to confirm whatever I'm getting from the computer. And the second thing is I encourage people to use benchmarking. You mentioned that, Julia. Some of the panelists already mentioned that. National, international benchmarking targets that you can compare your results versus other people as well, if you want to continue to improve. Thank you.
Thanks a lot, Manuel. Very valuable remark. So thank you everyone for joining us today. Thanks a lot for staying longer. A special thank you to our wonderful panelists today. Just a couple of technical remarks. Yes, we share all the recordings. Also, the recordings are available on our IFC page on the web page. Yes, we share the slides. Please do not worry about that. Very important that you fill in the survey on exit when we finish the webinar, and also you provide your name for the certificates, and then you will receive the certificates shortly. So thank you very much once again. We hope that you found it useful, and we look forward to seeing you again in our webinars, and Merry Christmas for those and Happy Holidays, winter holidays for those who celebrate. So Natasha, anything from you to add on? Thank you. Bye.
Not really. I'm happy that this webinar is just happening when the holiday season is approaching, so we can take a rest. Everybody can take a rest, and with the knowledge that we received, then have a fresh start in the new year and start applying the knowledge that we actually acquired today. So in the survey of on exit, please let us know what you think, give us any important comments and so on. And please be patient. The certificates will arrive within 14 days by December 31st, 2024. So we will have them in time for the new year. So please be patient about that. But the follow-up email with the slides and with the useful links to all our useful resources will be coming tomorrow or the day after tomorrow. If you don't have this email the day after tomorrow, so that's Friday night, please send us a message in response to the invitation, and we will check and we will make sure that you get that email, okay? So thank you very much for your participation, and